Hello there. This is Dr. Asan Hussain at the Department of Ophthalmology and Visual Sciences in Halifax, Nova Scotia. Thank you for joining. Today I'll be talking to you about orbital cellulitis. So just to be newsworthy, this recording is being done on the 21st of May. And just 3 days ago, some of my colleagues in the North American Society of Academic Orbital Surgeons have published this paper in Orbit, which is actually open access. And it is talking about an interesting and somewhat concerning finding of very significant orbital cellulitis, sinusitis, and intracranial abnormalities in 2 adolescents who had COVID-19. So, orbital cellulitis is a very serious condition, as we all know. And it is worth being aware of how it presents and how urgently it needs management. So the first thing to say is that the term orbital cellulitis implies that there is an infectious etiology which must be demonstrated. And Dr. Richard Allen has emphasized this also in his lectures. So when you use that term, it is important to be aware of that fact for 2 reasons. The first reason is that there are other conditions which can masquerade as a orbital cellulitis, when in fact it could be something like rhabdomyosarcoma or things which are more serious potentially. And the second reason is that your determination of the etiology and the likely microbiology of it will determine the appropriate therapy. So then second thing to say is that, we have to differentiate it from preseptal cellulitis, which again, by its term means there's an infective etiology, but the differentiation can sometimes be subtle. So the first thing I'm going to talk about is etiology. So we know that there's a balance normally between our own host flora and our defense mechanisms, because all of us have millions of microbes surrounding the orbit all the time on the eyelid, skin, and also within our sinuses. And we normally have intact host defenses, which are immune system or anatomic barriers, such as the orbital septum, to help maintain a microbe-free environment. And when you get orbital cellulitis, that implies that there has been either a weakening or breach of these normal host defenses, or alternatively, there are cases of microbial hypervirulence. And as shown in that paper, maybe COVID-19 as a virus did place these patients at an increased risk of developing secondary bacterial orbital cellulitis. So when it comes to normal defenses, in normally healthy individuals, we know that MRSA, for example, can pass posteriorly through a normal orbital septum. But in most cases, and outside the pandemic, it is usually a compromised defense system which results in orbital cellulitis. And the commonest category within that are sinusitis-related orbital cellulitis. Now, before I continue, I should mention there are 2 seminal landmark papers which you must know about in ophthalmology by Dr. Gerald Harris, published in 1994, and also in ophthalmology published by Liao and Harris in 2015. These will be mentioned in your academy manuals because they have really set a foundation for how we understand orbital cellulitis. So coming back to sinusitis, sinus obstruction results from allergic rhinitis or viral inflammation. And then you get secondary bacterial proliferation from these obstructions. And the inflammatory products that are produced, of course, potentiate the infection. And what's important to know is that there are age-related sinus anatomic differences, which determine the local conditions such as oxygen, CO2 availability, and pH. And that determines whether you have a predominantly aerobic or anaerobic flora within the sinuses. Now, with increasing age, the sinus cavities, of course, enlarge markedly, But what in fact happens is that the sinus ostium, the sinus ostia, they actually remain approximately the same size. So if you look at a child, the relative width of the sinus ostia in young children being bigger in comparison to the sinus size explains their greater incidence of acute sinusitis, because frequent upper respiratory tract infections tend to involve the nose and sinuses as a single structure. Therefore, younger children rarely achieve strict anaerobic conditions in their sinuses. But as we get older into adulthood, as the sinuses grow, but the ostia stay relatively the same size, you get almost complete sequestration and more complex infections, which can be anaerobic. You should also know that the anatomy there is very relevant. The thin bone separating the sinuses, particularly the ethmoid bone and the lamina papyracea, allows direct passage of bacteria through these small bony dehiscences and vascular canals. And orbital complications of sinusitis in the first decade of life usually results from disease in the ethmoid and maxillary sinuses. The frontal sinus first appears between ages 5 and 7, but does not fully develop until late adolescence. So as a cause of orbital cellulitis, that usually happens later in life. How else can your normal defenses be compromised? Well, it can occur through trauma, such as fracture, although Ben Simon's paper in ophthalmology in 2005 showed that orbital cellulitis following orbital fracture is very rare and more common when in fact there is concomitant paranasal sinus infection, or if the fracture has been left unrepaired and it breaks into a sinus. Of course, idle laceration, cutaneous abrasions, and orbital sinus foreign bodies are risk factors for developing orbital cellulitis. We know that post-surgical risks exist, such as glaucoma surgery. There have been scattered reports about implants causing secondary orbital cellulitis. I mentioned orbital fracture and orbital fracture surgery. Strabismus surgery has been mentioned. Retrobulbar alcohol and chlorpromazine injections. Orbital surgery, again, it is rare for people to get orbital cellulitis, but 2 cases were reported after enucleation and evisceration by Aaron Fay in OPRS in 2013. Case reports have also existed about sinus surgery, dental procedures, and eyebrow piercing. Be aware of endogenous spread. Patients who have immunodeficiency, you may get a bacteria such as Pseudomonas aeruginosa causing a septicemia. Patients can have liver abscesses from Klebsiella, which can spread to the orbit. Be aware of dental abscesses causing secondary bacterial infection, which I'll come to in a moment. Endophthalmitis can also result in secondary orbital cellulitis or pan ophthalmitis. And the common primary or secondary infections that can occur in an immunodeficient state may not just be bacteria. You can get fungal infections like mucormycosis, aspergillosis, and rarely Haemophilus influenza, which is less common now because of vaccination, but also HIV, these immunodeficient states such as HIV, diabetic ketoacidosis, myeloma, cancer chemotherapy, lymphoma, and use of steroids. So these are factors to be considered before you begin with examining the patient. Now, just a quick word on epidemiology. The Scottish Ophthalmic Surveillance Unit in the UK said there was an incidence of about 1.6 cases per 100,000 children in the UK, and about 0.1 cases per 100,000 adults for all forms of orbital cellulitis. 47% of children had an upper respiratory tract infection at the time of the orbital cellulitis, whereas 87% had sinus disease. And immunosuppression and trauma were the leading cause in adults. There was no racial or gender predilection. It was more common in the winter months due to the higher incidence of sinusitis and URIs. So how does a typical patient with orbital cellulitis present? Well, usually it's quite a acute or subacute onset. It's a quick onset. Patients feel sick, they feel unwell. There's usually a systemic marker such as fever, They have pain, particularly with eye movements. There can be vision loss or damage. There can be double vision. There's a history of sinus infection, surgery, or trauma, and they may, of course, have sinus symptoms. Relevant medical history is diabetes mellitus, especially with ketoacidosis. There may be a history of immunocompromise. What do the patients present with? Well, the general signs, of course, can be the eyelid edema and erythema, but that is, of course, also present in preseptal cellulitis. When you're talking about orbital cellulitis, you're basically saying that the infection has spread beyond the orbital septum. So patients can then get proptosis, they can get restricted extraocular movement or pain with eye movement. You're worried then about their vision, of course, decreased vision. They can get an RAPD if vision is now starting to become compromised. They may get reduced corneal sensation if there is involvement of the trigeminal nerve or the surface of the eye. We've mentioned eyelid edema, erythema, conjunctival injection, chemosis, fever, and look for an eschar on the roof of the mouth or in the sinuses, which can be an indication of mucormycosis. You will then proceed, of course, to do your clinical examination. You will check their vision, their color vision, their motility, the Hertel or exophthalmometry. You will do a complete anterior and posterior exam. You will proceed to imaging. A CT is required urgently. Look for orbital fat stranding. Look for an orbital abscess. That may well determine that you may need surgery. Look for adjacent sinus disease. An MRI is less important in these urgent cases, but can be useful to determine the extent of soft tissue involvement. You should do a CBC, you should do a CRP, particularly a CRP because that may also guide you if you want to use steroid treatment. There have been some papers about using steroids for inpatients during their course of orbital cellulitis after they've had initial antibiotic treatment. You may also want to do blood cultures. You may want to consider doing biopsy of any unusual presentations for fungal or atypical mycobacteria. And in terms of intervention, we'll come to that, but be aware that in Harris's paper in OPRS in 1996, CT scan findings are not necessarily predictive of how the patient is going in terms of their actual clinical course. In fact, the CT scan findings can lag behind the clinical picture, and that should not be used as your routine source of monitoring. Your clinical examination is your main route. So risk factors we've talked about already, but the presence of sinus disease, presence of dacryocystitis, if they had a tooth abscess or previous trauma or facial surgery, and of course a patient who has a compromised immune function. What are your differential diagnoses? Well, be aware of other non-bacterial causes of orbital cellulitis, such as fungus. Be aware of necrotizing fasciitis. That's something I've talked about in another case. Be aware of myiasis, particularly in the United States. There are different organisms which can parasitize around the orbit and cause a secondary picture of cellulitis. Inflammation, orbital inflammation, such as with thyroid eye disease, idiopathic causes, GPA, can mimic orbital cellulitis or infective cellulitis. Trauma, such as hemorrhage, orbital emphysema. Malignancy, such as a metastatic tumor from the breast, lung, prostate. Lymphoproliferative disease, retinoblastoma. A ruptured dermoid cyst. Vascular causes, such as CCF, cavernous sinus thrombosis, orbital venous malformations, can also mimic this condition. So how do you manage these patients? Well, it will, like I said earlier, it will also be determined by your etiology, microbiology, and immune status of the patient. So get your infectious diseases colleagues involved if you need to, and get your ENT colleagues involved. If there's a subperiosteal abscess and significant sinus disease, the patient may require sinus drainage and drainage of the abscess. In terms of medical therapy, there are various guidelines, depending on your local hospital guidelines on which antibiotics to use. You will need to use IV antibiotics, consider clindamycin, vancomycin, and a dual therapy with a third-generation cephalosporin. If the patient has compromised defenses, you may need to use other agents. As we mentioned with the seminal paper by Gerald Harris, in a young child, so these are criteria which are things to think about. So in a child under 9, usually they have a single pathogen which is an aerobic infection because of the sinus anatomy. But then as they get older, over 9 years old, the increased prevalence of polymicrobial disease occurs because of the change in anatomy. You may want to give them a nasal spray, monitor them closely, mark out the area of the orbital cellulitis, and monitor that daily. There is some debate on corticosteroids. We will leave that to another day. Surgery is usually reserved for hypervirulent organisms where you may need to do debridement, such as with necrotizing fasciitis. And when do you manage a subperiosteal abscess? Well, as per Gerald Harris's paper and Liao's paper in 2015, urgent drainage is usually required for the following 6 findings: a large subperiosteal abscess, an SPA which extends superiorly or inferiorly beyond the medial subperiosteal space, frontal sinus involvement, intracranial extension, a presumed anaerobic infection, and patients over 9 years of age. And I will refer you to that paper and also your manual to look up those indications. Finally, complications. If these are patients that are not treated appropriately, it can lead to subperiosteal or orbital abscesses and vision loss, central retinal artery occlusion, superior ophthalmic vein thrombosis, orbital compartment syndromes, and in fact, frank meningitis and cranial involvement and death in unfortunate cases. So this is a very serious condition which has to be recognized and managed early on. So I wanted to give you an example of this lady who I treated very early on in my time in Halifax with really a very fulminant orbital cellulitis, who had drainage also by ENT performed. But what we in fact found was that she had an orbital abscess, and this was related to a dental abscess on further evaluation. This abscess measured about 16 by 8 millimeters, and it required 2 drainages by myself. She did very well in the end. We preserved her vision. The proptosis resolved. She needed an urgent lateral canthotomy canthelysis to relieve her orbital pressure. And you can see that laterally on her eyelid, which I then repaired secondarily later on. And she did very well. So a condition to be well aware of. Okay, and that's the end of that case. If you have any questions, you can contact me as mentioned on the slide.
Awesome.